Welcome to Pediatric Case Review, Musculoskeletal Disorders Series. Today's lecture is a comprehensive case-based review of Clubfoot, also known as Talipes Equinovarus, designed for general pediatric physicians. We will work through 14 carefully constructed clinical cases covering the full scope of this common congenital condition, including clinical presentation and the hallmark features, physical examination findings, palpation and bony landmarks, pathophysiology, radiographic investigations, prenatal diagnosis, the Ponseti method sequence, managing residual equinus, bracing protocols, relapse, dynamic gait abnormalities, associated anomalies, and differential diagnosis. Let us begin. Case 1. A 2-day-old male infant is brought to the pediatric clinic for a foot deformity. He was born at 38 weeks gestation via spontaneous vaginal delivery. Family history is significant for clubfoot in a paternal uncle. The right foot is found to be in a rigid Equinovarus position, while the left foot appears normal. No other congenital anomalies are noted, and the infant is otherwise healthy. What is the most likely diagnosis? Option A, positional clubfoot. Option B, congenital Talipes Equinovarus, also known as clubfoot. Option C, metatarsus adductus. Option D, calcaneovalgus foot. The correct answer is option B, congenital Talipes Equinovarus, or clubfoot. The hallmark clinical features of true clubfoot follow the cave mnemonic, which stands for 4 components. Cavus refers to a high medial longitudinal arch adduction, means the forefoot turns inward. Varus means the heel tilts inward. Equinus means the foot points downward. The deformity is rigid and present at birth, and crucially, it cannot be passively corrected to a neutral position. This rigidity is the single most important feature that distinguishes true clubfoot from positional deformities, which are flexible and can be gently corrected. Early recognition is critical because the Ponseti method can begin within the first week of life for optimal outcomes. Case 2. A 3-day-old female infant is brought to the pediatric clinic for a routine newborn examination. The delivery was uncomplicated at 39 weeks gestation. During the physical examination, the left foot appears to be in an abnormal position. The sole of the foot is facing medially, and the foot appears smaller than the right foot. When you attempt to gently manipulate the foot into a normal position, there is significant resistance, and you cannot achieve full correction. What is the most characteristic feature that distinguishes true clubfoot from positional foot deformities? Option A. The foot can be passively corrected to neutral position. Option B. The sole faces laterally rather than medially. Option C. The foot is rigid and cannot be passively corrected to neutral. Option D. The affected foot is larger than the contralateral side. The correct answer is option C. The foot is rigid and cannot be passively corrected to neutral. In true clubfoot, the sole of the foot faces medially and may even point upward. This orientation results from the combination of all 4 cave components acting simultaneously. The foot appears twisted inward with the plantar surface visible from the front. This distinctive positioning is pathognomonic for clubfoot deformity. The key clinical insight is straightforward. If the foot corrects fully with gentle passive manipulation, it is a positional deformity that can be managed conservatively with stretching and observation. If it does not correct, it is true congenital Talipes Equinovarus, and the Ponseti method must begin promptly. Case 3. A 3-week-old male infant is brought to your clinic for evaluation of a suspected foot deformity noted at birth. He was born at full term via normal vaginal delivery with no complications. Family history is significant for clubfoot in a maternal uncle. On examination, the infant is alert and active with normal growth parameters. The right foot appears smaller than the left with a visible deformity. The foot position is rigid with the sole facing medially. Range of motion shows significantly limited passive correction. The heel feels soft and doughy to touch. The calf muscle is noticeably underdeveloped compared to the contralateral side. Neurological examination is normal with intact tone, reflexes, and spontaneous toe movement. Which physical examination finding is most characteristic of idiopathic clubfoot in this infant? Option A. Flexible deformity that can be passively corrected to neutral. Option B. Rigid foot deformity that cannot be passively corrected to neutral. Option C. Painful foot with warmth and swelling on palpation. Option D. Normal calf muscle development with isolated forefoot involvement. The correct answer is option B. Rigid foot deformity that cannot be passively corrected to neutral. This is the hallmark physical finding of true congenital Talipes Equinovarus and the most important differentiating feature. Comparing positional clubfoot with rigid clubfoot reveals 5 key differences. Flexibility. Positional clubfoot is flexible and correctable, while true clubfoot is rigid and non-correctable. Passive range of motion. Full range is achievable in positional deformity, while true clubfoot shows limited dorsiflexion and abduction. Foot feel. Positional deformity feels soft and pliable, while true clubfoot feels firm and resistant. Severity. Positional deformity is mild, while true clubfoot is a severe, fixed deformity. Treatment. Positional deformity responds to stretching and observation, while true clubfoot requires the Ponseti method. Additional findings in idiopathic clubfoot include calf muscle underdevelopment and a soft, doughy heel on palpation. Case 4. A 4-week-old infant with right-sided clubfoot is being examined by a pediatric orthopedist. During physical examination, the physician performs systematic palpation of bony landmarks to assess severity. The infant is calm and cooperative. History reveals full-term delivery, no prenatal complications, and a positive family history of clubfoot in a maternal uncle. Physical findings show the right foot in rigid Equinovarus position, smaller than the left foot, with underdeveloped calf muscles. During palpation of the affected foot, which bony landmark finding is most characteristic of Talipes Equinovarus? Option A. Easily palpable lateral malleolus with normal positioning. Option B. Prominent talar head in the sinus tarsi area. Option C. Normal navicular bone position medially. Option D. Calcaneus readily palpable in neutral position. The correct answer is option B. Prominent talar head in the sinus tarsi area. This is a pathognomonic sign of clubfoot deformity, directly indicating medial displacement of the navicular bone. When the navicular displaces medially, it creates a palpable gap in the sinus tarsi region, allowing the talar head to become unusually prominent and easily felt by the examining hand. For key palpation findings follow from this anatomy. First, navicular displacement creates a palpable gap in the sinus tarsi. Second, talar head prominence is easily felt laterally in the sinus tarsi area. Third, the medial malleolus becomes difficult to palpate because of the medial soft tissue contracture. Fourth, this finding differentiates true clubfoot from positional deformity on clinical examination alone without requiring imaging. Case 5. A 4-week-old male infant with bilateral clubfoot undergoes research tissue analysis during corrective surgery. Histological examination of muscle and tendon samples reveals specific pathological changes, including shortened muscle fascicles in the posterior compartment muscles, increased pennation angle in affected muscles, and dense collagen fiber deposition in tendons. Imaging findings show medial and plantar deviation of the talar neck, calcaneus positioned in varus alignment, and the navicular bone displaced medially. Which of the following best explains the primary pathophysiological mechanism underlying clubfoot deformity? Option A. Primary neurological deficit causing muscle paralysis and secondary deformity. Option B. Congenital absence of key tarsal bones leading to structural collapse. Option C. Muscle imbalance with connective tissue abnormalities and shortened fascicles. Option D. Intrauterine compression causing temporary positional foot deformity. The correct answer is option C. Muscle imbalance with connective tissue abnormalities and shortened fascicles. The primary pathology in congenital Talipes Equinovarus involves muscle imbalance between tight posterior medial structures and weak anterior lateral structures. For key pathological findings, define this mechanism. First, shortened muscle fascicles with an increased pennation angle are found in posterior compartment muscles. Second, abnormal collagen deposition occurs in tendons and ligaments, increasing stiffness. Third, the bony changes, including medial talar neck deviation and calcaneal varus, develop secondary to the soft tissue forces in progress over time if untreated. Fourth, genetic factors and environmental factors combine to drive muscle imbalance and progressive deformity. Understanding this mechanism explains why the Ponseti method, which sequentially corrects the soft tissue deformities from distal to proximal, is so effective. Case 6. A 6-week-old male infant with bilateral clubfoot undergoes initial radiographic evaluation. He has been in Ponseti casting for 4 weeks with good clinical improvement. Plain radiographs are obtained to assess bony alignment and correction progress. The anteroposterior talocalcaneal view shows specific angular measurements. On the anteroposterior talocalcaneal view, also known as the kite view, what is the characteristic measurement finding in clubfoot? Option A. Talocalcaneal angle greater than 40 degrees. Option B. Talocalcaneal angle less than 20 degrees. Option C. Talocalcaneal angle between 25 and 35 degrees. Option D. Talocalcaneal angle greater than 45 degrees. The correct answer is option B. Decreased talocalcaneal angle on the anteroposterior view, specifically less than 20 degrees. The talocalcaneal angle reflects the relationship between the talus and calcaneus and is the most reliable radiographic indicator of clubfoot severity and correction progress. For key points, define the radiographic interpretation. The normal talocalcaneal angle on anteroposterior view ranges from 20 to 40 degrees. In clubfoot, this angle is typically less than 20 degrees because the calcaneus is inverted under the talus. This decreased angle indicates the characteristic heel varus deformity. As Ponseti casting corrects the deformity, the talocalcaneal angle progressively increases toward the normal range, providing an objective measure of treatment response. A single normal anteroposterior X-ray in the emergency department at 6 hours post-exposure does not exclude injury, and this principle of serial monitoring applies equally to clubfoot treatment progress. Case 7. A 28-year-old pregnant woman at 20 weeks gestation presents following a routine anomaly scan that reveals bilateral foot abnormalities. The fetal feet appear to be in a fixed Equinovarus position, and no other structural anomalies are detected. Family history is significant. The patient's brother had clubfoot that required surgery. What is the earliest gestational age at which clubfoot can be reliably diagnosed using prenatal ultrasound? Option A, 12 to 13 weeks gestation. Option B, 16 to 18 weeks gestation. Option C, 20 to 22 weeks gestation. Option D, 24 to 26 weeks gestation. The correct answer is option A. Ultrasound can detect clubfoot as early as 13 weeks gestation, with reliable detection from 13 to 15 weeks. For important points, define prenatal diagnosis of clubfoot. The earliest detection is possible at 13 to 15 weeks gestation, when the characteristic clubbed foot appearance becomes visible on ultrasound. Three-dimensional ultrasound improves diagnostic accuracy and allows better characterization of the deformity. Associated structural anomalies should always be systematically evaluated, as clubfoot can occur in the context of neuromuscular conditions, genetic syndromes, or other malformations. The clinical pearl that transforms outcomes. Prenatal diagnosis allows for early counseling and planning of postnatal treatment. The Ponseti method can begin within the first week of life for optimal results, and families who are counseled prenatally are better prepared to engage with this demanding but highly effective protocol. Case 8. A 2-week-old male infant presents with bilateral clubfoot deformity. After confirming the diagnosis, you decide to initiate the Ponseti method of treatment. The parents are counseled about the treatment protocol and express understanding of the commitment required. Physical examination shows the right foot in a rigid Equinovarus position with a high arch and the left foot with a similar but slightly less severe deformity. No associated anomalies are detected, neurological examination is normal, and family history is positive for clubfoot in a maternal uncle. According to the Ponseti method, what is the correct sequence of deformity correction following the cave principle? Option A, cavus, then adduction, then varus, then equinus. Option B, cavus, then adduction, then varus, then equinus, but in the opposite order. Option C, varus, then equinus, then cavus, then adduction. Option D, adduction, then cavus, then equinus, then varus. The correct answer is option A, cavus, adduction, varus, equinus, following the cave sequence. The Ponseti method follows the cave sequence for systematic correction, and this specific order is crucial for successful treatment outcomes. The visual algorithm progresses as follows. Weeks 1 and 2 address cavus by supinating the forefoot to correct the high arch. Weeks 3 and 4 correct adduction by abducting the forefoot. Weeks 5 and 6 address varus by correcting the heel inversion. Weeks 7 and 8 address equinus, which is the plantar flexion deformity. 3 clinical pearls govern the technique throughout. Never pronate the foot during correction, as this worsens the deformity. Cast changes are performed weekly with gentle manipulation at each session. Achilles tenotomy is needed in 85 to 90% of cases to complete correction of the residual equinus deformity. Case 9. A 6-week-old infant with unilateral clubfoot has undergone serial casting with the Ponseti method for 6 weeks. The cavus, adduction, and varus have been successfully corrected, and the foot can now be abducted to 70 degrees. However, dorsiflexion remains limited to -15 degrees despite adequate correction of the other deformities. The parents are compliant with treatment, and the casting technique has been appropriate. What is the most appropriate next step in management? Option A, continue serial casting for another 3 to 4 weeks. Option B, perform percutaneous Achilles tenotomy. Option C, initiate foot abduction orthosis immediately. Option D, refer for comprehensive surgical release. The correct answer is option B. Perform percutaneous Achilles tenotomy. When the foot reaches 60 to 70 degrees of abduction but dorsiflexion remains limited, this indicates isolated Achilles tendon contracture preventing the final correction. Continuing casting will not resolve this because the problem is now structural rather than positional. The tenotomy is indicated for 4 reasons. It corrects residual equinus deformity that persists after successful serial casting of the other components. The Achilles tendon contracture physically prevents full dorsiflexion and must be released. It is a simple outpatient procedure with excellent results and minimal risk. It is performed precisely when the foot reaches 60 to 70 degrees of abduction, as is the case in this patient. After tenotomy, a final cast is applied for 3 weeks while the tendon heals in the lengthened position, followed immediately by the foot abduction orthosis bracing protocol. Case 10. A 4-month-old infant with bilateral clubfoot has just completed 8 weeks of serial casting with the Ponseti method, followed by percutaneous Achilles tenotomy and final casting. The feet are now well corrected with good abduction and dorsiflexion. The parents are ready to begin the bracing phase to maintain correction and prevent relapse. What is the standard protocol for foot abduction orthosis use in this patient? Option A, where the foot abduction orthosis 12 hours daily for 6 months, then discontinue. Option B, where full-time for 2 weeks, then nighttime only until age 2 years. Option C, where 23 hours daily for 3 months, then nighttime and naps until age 4 to 5 years. Option D, where only during sleep from the beginning until age 3 years. The correct answer is option C, with a foot abduction orthosis 23 hours per day for the first 3 months, then transition to nighttime and naps until age 4 to 5 years. The bracing protocol follows a structured 2-phase schedule. During the intensive phase, which covers the first 3 months, the brace is worn 23 hours per day and removed only for bathing. During the maintenance phase, from 3 months to 4 years of age, the brace is worn during nights and naps, providing 12 to 14 hours of daily wear. The first 2 years of life represent the critical period of highest relapse risk and require strict compliance. Follow-up continues until age 4 to 5 years with regular monitoring for signs of relapse. The most important clinical warning to communicate to every family: noncompliance with bracing is the #1 cause of clubfoot relapse, accounting for up to 37% of cases. Bracing is not optional. It is the most critical phase for long-term success. Case 11. A 2-year-old boy returns to your clinic for routine follow-up after successful Ponseti treatment for bilateral clubfoot completed at 8 months of age. His mother reports that the right foot has been starting to turn in again over the past 2 months. History reveals bilateral idiopathic clubfoot, 7 weeks of serial casting, bilateral percutaneous Achilles tenotomy, and final cast removal at 8 months. Parents were counseled on the bracing protocol at discharge. Current examination shows the right foot with mild adduction and supination, dorsiflexion limited to neutral, good correction maintained on the left, and the child walking with a slight in-toeing on the right. What is the most likely primary risk factor for this relapse? Option A, inadequate initial correction during the casting phase. Option B, poor compliance with foot abduction orthosis bracing. Option C, delayed walking development beyond 18 months. Option D, bilateral involvement requiring asymmetric treatment. The correct answer is option B, poor compliance with the foot abduction orthosis bracing protocol, which is more precisely described as noncompliance with the bracing protocol. Bracing noncompliance is the #1 cause of relapse, accounting for up to 80% of cases. Most relapses occur within the first 2 years of life, which is precisely why the critical period of strict compliance is emphasized so heavily. Early detection of relapse allows for successful retreatment. The management algorithm for detected relapse depends on severity. Mild relapse is managed by resuming Ponseti casting followed by strict bracing protocol. Severe relapse may require consideration of surgical options, including tibialis anterior tendon transfer. All cases return to long-term bracing protocol after retreatment. 4 prevention keys should be reinforced at every clinic visit: thorough parent education, regular follow-ups, proper brace fitting, and addressing any skin issues promptly to maintain brace comfort and compliance. Case 12. A 4-year-old male with a history of bilateral clubfoot treated with the Ponseti method at birth presents because parents have noticed a new gait abnormality. During gait analysis, the child demonstrates supination of the right foot during the swing phase of walking. He bears weight on the lateral border of his foot and shows difficulty with heel strike. The left foot shows a normal gait pattern. What is the most likely name for this dynamic gait abnormality? Option A, rocker bottom deformity. Option B, residual cavus foot. Option C, dynamic supination. Option D, equinus contracture. The correct answer is option C, dynamic supination. Dynamic supination occurs when the tibialis anterior muscle becomes overactive during the swing phase of gait, causing the foot to supinate and the child to bear weight on the lateral border. It is the most common gait abnormality identified after clubfoot treatment. It results from overcorrection or residual muscle imbalance following the treatment process. When persistent and functionally limiting, it may require tibialis anterior tendon transfer. This surgical procedure redirects the muscle pull to improve foot position and restore a more balanced gait pattern. The key clinical take-home: gait analysis is an important component of long-term clubfoot follow-up and should be performed at every visit once the child begins walking, as dynamic supination can develop even after apparently successful correction. Case 13. A 6-week-old female infant presents with bilateral rigid clubfoot deformities. She was born at 37 weeks gestation following an uncomplicated pregnancy. Physical examination reveals symmetric Talipes Equinovarus bilaterally with inability to passively correct either foot. The infant appears otherwise well with a normal neurological examination. Her parents are concerned about potential associated conditions and request comprehensive screening. Which additional musculoskeletal screening examination is most indicated in this patient with bilateral clubfoot? Option A, complete spinal examination including assessment for spina bifida occulta. Option B, detailed hip examination for developmental dysplasia of the hip. Option C, comprehensive hand and wrist examination for syndactyly. Option D, thorough shoulder examination for congenital torticollis. The correct answer is option B, detailed hip examination for developmental dysplasia of the hip. The connection between bilateral clubfoot and developmental dysplasia of the hip is well established and clinically important. 3 key points define this relationship. Bilateral clubfoot increases the risk of developmental dysplasia of the hip by 3 to 4 times compared to the general population. Hip ultrasound is specifically recommended at 6 weeks of age for all infants with bilateral clubfoot. Both conditions share genetic pathways and intrauterine positioning factors, explaining their co-occurrence. Additional associations that should be considered in all clubfoot cases include neurological conditions such as myelomeningocele and arthrogryposis, genetic syndromes such as diastrophic dysplasia and Freeman-Sheldon syndrome, and other musculoskeletal conditions such as congenital vertical talus and metatarsus adductus. The clinical pearl to apply in every bilateral clubfoot case: always examine the hips. Early detection of developmental dysplasia of the hip is crucial for optimal outcomes in both conditions. Case 14. A 6-week-old female infant is brought to your clinic by concerned parents. The parents notice that the baby's left foot appears to turn inward. She was born at 39 weeks gestation via normal vaginal delivery with no complications and no family history of foot deformities. On physical examination, the left forefoot appears adducted and turned inward. Crucially, the deformity is easily correctable with gentle passive manipulation, and full range of motion is achieved when corrected. There is no heel varus or equinus deformity. Hindfoot alignment is normal, and no cavus deformity is present. What is the most likely diagnosis for this infant's foot condition? Option A, congenital Talipes Equinovarus. Option B, metatarsus adductus. Option C, calcaneovalgus foot. Option D, congenital vertical talus. The correct answer is option B, metatarsus adductus. This case demonstrates the critical differential diagnosis between clubfoot and metatarsus adductus. Comparing these two conditions across 5 features clarifies the distinction. Flexibility: clubfoot is rigid and not correctable, while metatarsus adductus is flexible and passively correctable. Hindfoot position: clubfoot has varus with an inward tilted heel, while metatarsus adductus has a normal heel position. Components: clubfoot involves all 4 cave components, while metatarsus adductus involves forefoot adduction only. Severity: clubfoot is a severe multiplanar deformity, while metatarsus adductus is a mild single-plane deformity. Treatment: clubfoot requires the Ponseti method with possible surgery, while metatarsus adductus is managed with observation and stretching exercises. The prognosis for metatarsus adductus is excellent. It often self-corrects by age 4 to 6 years. The key differentiator to remember: flexibility and hindfoot involvement distinguish clubfoot from metatarsus adductus. Before we close today's session, we want to share an important resource with you. The Pediatric Case Review community on Patreon gives you access to a comprehensive, system-organized clinical education library. The complete video library organizes all lectures by medical system, including musculoskeletal, cardiovascular, respiratory, and more, for easy navigation and comprehensive learning. All presentation slides are available as downloadable high-resolution images for offline study and question practice. Interactive learning resources include practice cases, review questions, and case-based discussions to enhance your clinical knowledge at your own pace. If you would like to join and get the subscription details, simply comment below this post, and we will message you directly. And that brings us to the end of today's comprehensive case-based review of Clubfoot, Talipes, Equinovarus. Over 14 cases, we covered this condition from newborn recognition to long-term follow-up. 4 essential takeaways should guide your clinical practice going forward. First, early recognition and prompt Ponseti method treatment are crucial for optimal outcomes. The Ponseti method, starting within the first week of life, achieves successful correction in over 95% of cases. Second, strict adherence to the bracing protocol prevents relapse in over 90% of cases. Noncompliance is the #1 cause of relapse and must be prevented through education at every visit. Third, case-based learning enhances clinical decision-making skills, and the differential diagnosis between clubfoot, metatarsus adductus, and positional deformities is a high-yield clinical skill for every general pediatrician. Fourth, a multidisciplinary approach involving pediatrics, orthopedics, and physiotherapy ensures comprehensive patient care. Please follow Pediatric Case Review for more musculoskeletal disorder reviews. Comment below with your questions, and stay tuned for our next lecture on developmental dysplasia of the hip.